So some competing interests. I'm on the Speakers Bureau of Ferring in the US. And I will start first with what we all should know extremely well, which is basically what happens in a natural cycle. For us to really understand what goes on when we do ovulation induction, we have to at least have a pretty good grasp of physiology. So as we all know, there's the follicles early on, there's recruitment by FSH, of course. LH is still very low at that point. And just right before ovulation, the increase in LH and subsequently progesterone is critical for the triggering of the LH surge and the ovulation. And in a natural cycle, again, this is a model what happens after ovulation, the increase in LH, which is really substantial. There's a short peak of FSH also that happens, and then you have basically the luteal phase. But when we do ovulation induction, whether you do step up or step down, and most of us probably do step down, even though there's, as we discussed yesterday, there's data that once you start recruitment, there's really nothing that you should do afterwards. Then we don't use LH to trigger ovulation, we use hCG. If we have to use LH to trigger, we need a humongous dose of LH to try to trigger ovulation. And obviously, you get the hCG that really disappears over time, and even by about 7 days after the hCG shot, you can still detect hCG in blood. So what determines follicular fate earlier? So by the time a follicle is very small, so this is even the non-recruitable, not the FSH-dependent ones, there's practically no LH expression in granulosa cells. By the time a follicle or an antral follicle is 5 to 10 millimeters, which again, when we start stimulation, this is the type that you'd like to have to recruit follicles. LH receptor is observed in 80% of granulosa cells. And I've been around the world where people start adding hMG, for example, on day 6 or day 7 of the cycle. And that's really too late, not because of the steady state parameter, but by the time a follicle is recruitable, 80% of them have LH receptors on granulosa cells. By the time it's 10 millimeters, basically it's 100% expression at this point. And we all know that hCG is significantly more potent than LH. So 7 is a number you should remember, and the half-life is substantially longer. So the half-life of hCG is about 36 hours, while that of LH is actually about 1.3 hours. So a huge difference between LH and hCG. And the only study I could find looking at half-life of recombinant LH is this study from Sruji from actually Harvard in JCNM in 2007, where they looked at endogenous LH half-life, and then they looked at that for recombinant LH, and the half-life is exactly the same. So the half-life is 1.35 hours. So when you give recombinant LH, it's practically gone from your system very, very quickly. So what about replacing FSH by LH-hCG? So in Europe, in the early, actually around 2000, Serono decided to pull off Pergonal off the market. So there was no hMG that's available. And people very quickly realized that actually the cycle is not going that well. So people started actually adding hCG to trigger, to at least get a better follicular growth and better egg quality. And so low dose hCG, so once FSH changes follicular growth, by the time a follicle is about 14 millimeters in diameter, you can actually replace the FSH with hCG, and you can drive the growth, and you can trigger with ovulation, get oocyte, and they're perfectly fine. And pregnancies have reported in 2002 by Marco Filicori, and then he published another paper in FNS in 2005 when you actually give FSH in group 1 and no hCG. Then in group B, you give 50 of FSH and 50 IUs of hCG. The third group gave 25 of rec-FSH and 100, and group D, no FSH and 200. So that's when the follicle is about 14 millimeters. So 200 IUs of hCG, which basically you multiply by 7, that's 1,400 IUs of LH. And the pregnancy rate was actually identical. So this is the data from that study. The duration of stimulation was identical. FSH stimulation was significantly lower because you're replacing FSH with actually hCG. hCG duration was about 3 days. So by the time you're about 14 until you get about 18 to 20, That's about your 3 days, obviously substantially lower dose of FSH because you are replacing that. Number of oocytes was identical, number of embryo transfer was 2.5, and the pregnancy rate was exactly the same. So you can drive your follicle once they're dominant, about 13, 14 millimeters, you can actually continue the cycle with just using hCG. That's another study from the Belgian group where they did basically the same thing. You get to basically by day 7, which is around 13 to 14 millimeters, replace with 200 IU of hCG and basically finish your IVF cycle. And we all used to be told that there's an LH threshold and LH ceiling, and with 1400s of LH, it seems to be no ceiling at that point. So what about endocrine profile? What do you find when you replace FSH with hCG at this point? FSH level, obviously, when you replace it, is going to drop. The hCG level is going to rise because there was no hCG before, and now you're adding it. The estradiol level is identical, and the progesterone level was identical in that study. So that's another study from Bokil where he did basically the same thing, low dose hCG. Obviously, the dose of FSH is going to be substantially lower, identical number of oocytes. And actually, in this study, the delivery rate was higher, but it was not statistically significant because the numbers were really small. And this is a systemic review that was published in the Cochrane Review in 2013, looking at all the data when you replace hCG, when you add hCG in the late follicular phase. Ongoing pregnancy rate is not different and crosses 1, so 1.1. OHSS, 5 studies, 351 women, no difference. Number of cumulus ovarian complexes were the same. FSH consumption, as you would expect, was substantially lower when you replace hCG. So this is the conclusions of that study, that basically there's reduced number of small preantral follicles, stimulated growth independent of FSH administration. It may lower the risk of OHSS, but no substantial data. Do we have any recent data looking at this? So this is the study from Tucson from JCNM in 2014, where basically comparing, adding hCG and finding out what really goes on. So the first group got absolutely no hCG, got 150 of FSH. I think Dr. Anderson is on the senior author in that paper. Then you add 50 of hCG, then you add 100, and you add 150. Progesterone level was really not that different. Estradiol level peaked at the 100 and was slightly lower in the 150. Androstenedione, basically the same thing. So it looks like 100 of hCG was ideal for that patient population. But they did not go beyond 150 to see if there's a drop at that point or not. What about top quality embryos? So this is very important, and it mirrors one study I'm going to discuss earlier. So in the REC-FSH alone, the number of top quality embryos per patient was 0.8. In the 50, it was 0.5. With 100, 1.2. With the 150, it's 1.5. So the more hCG you gave, the higher the number of top quality embryos you're going to find. And one of the medications that we use, obviously, is Menopur. And Menopur is very different than any other HMG that's on the market. Menopur has practically no LH in it. And more than 95% of the LH-derived activity is actually from hCG. So there's 10 IUs of hCG in every vial of Menopur. Even the old ones, the old preparations, all had to be spiked with hCG to get to basically that 75 IU LH activity. But there are many preparations of HMG in different parts of the world, but the only one that has hCG is Menopur. And in the US, the only HMG we have available is actually Menopur. So this hCG does a lot of things. Okay. So what about ovarian stimulation? In our daily practice, what do we do? So this is data from the MERIT trial that was published in 2006. This is the embryology data that was published by Zibi. So again, this is like the study I showed you before from Bokil, that the number of top quality embryos is higher in Menopur versus gonal F. And therefore, the implantation rate you would expect when you're replacing a single embryo or 2 embryos at that point the ongoing implantation rate would be substantially higher when you're replacing a better top quality embryo at this point. And this slide nearly mirrors the study that Dr. Anderson did, which is with higher level of hCG as early as day 6, because actually when you draw blood on your patients with Menopur, you can detect hCG at every single time point. I'm going to show you some data on this. But if your hCG in the lower quartile, less than 25%, the number of top quality embryos is going to be the lowest. And the higher your hCG level on day 6, the higher the number of top quality embryos that you're going to have, as early as day 6. So if you go and you start your Menopur later, this is not going to be the case. And as I showed you in the earlier slide, the LH activity is detected in 80% of granulosa cells in cells that are in follicles that are as low as 5 millimeters. So again, this is in a, when you look at absolute data, if your hCG is between 0 and 1.5, only 0.6 top quality embryos. By the time it's more than 3, it's 1.24. So a substantial improvement at this point. And this beautiful slide looks at what happens with increasing hCG. As you know, the LH level does not change. There's really no LH in Menopur. But as hCG levels increase, the live birth rate is going to increase. No LH difference. The key is hCG. Now, do we have any other data? This is a study of mine that I presented at the ASRM last year. When you look at a group using mono-Menopur, so Menopur only for ovulation induction versus a mixed protocol of RAC FSH plus Menopur, you can measure hCG level at every single time point. And as obviously you would expect to have a higher hCG level in mono-Menopur versus mixed protocol, and these are substantially different. But remember, even at that point, I think the highest hCG level that I've seen was 7 or 8. So it's a very low amount of hCG, but it's detectable at every time point. Now, what about endocrine profile? So this is again from the MERIT trial. There are substantial differences between RAC FSH and hMG. The peak FSH level is about 18. Okay, this is a classic question I used to ask fellows, and very few people actually, or attendings, and very few people know this, that your FSH level by the day of hCG administration is only about 18 to 16. So if you have a patient that starts their FSH at 22 or 25, you're clearly not going to do anything for these patients. LH level is the same. Why? There's practically no LH in Menopur. It's all hCG. And again, this is another study that looks exactly at what my data was. It's about 3, and that's what you see at the end of simulation in the MERIT trial. Estradiol level, if you would think the 2-cell 2-gonadotropin theory, you're going to get a higher estradiol level in hMG versus RAC FSH. But this paper was the first one that really looked at progesterone level on the day of hCG. And that's the first paper that really documented a difference between RAC FSH versus Menopur. And that was substantially higher in the RAC FSH. Androstenedione and testosterone, as you would expect, again, the 2-cell 2-gonadotropin theory, you're going to have a substantially higher androgens and therefore better oocyte quality. These are, the androgens are really food for the cumulus cells. So now people come and say, oh, you know, we have fewer small-sized follicles with Menopur compared to FSH. So the total number of follicles obviously is going to be higher in RAC FSH versus hMG. And that was a selling point for these companies that manufacture recombinant FSH, is you get more oocytes, and therefore you get more oocytes at every single time point. This is what they saw in the MERIT trial, but there was no differences in the follicles that were above 12 millimeters. So you get about 1.8 eggs more when you do recombinant, but these are eggs that are not going to lead to a nice embryo. And again, there's differences right here, but that's in the MERIT trial. Now, what about Megaset? So Megaset, as you know, this is the paper that was published in February of 2012 using antagonist-based protocol comparing Purigon versus Menopur. So again, you would see that 1-point egg difference, but no differences right here in the 15 to 16 or the more 17. So there's no difference at that point in the follicles that are going to lead to a mature oocyte and therefore embryos. No difference once you cross about 15. What do these small follicles increase your odds for? OHSS. Okay. Now let's talk about bioactivity a little bit. So what about adding recombinant LH to recombinant FSH? Does this work as well as if you're using hMG? So this is the first meta-analysis by Kolibionakis looking at REC-FSH plus REC-LH versus REC-FSH. Absolutely no difference in outcome. And this is Koenig's meta-analysis in 2012, specifically in women less than 30, older than 35. Absolutely no difference between REC-FSH plus REC-LH versus REC-FSH. And I'm going to review a couple of recent data that just came out. So this is the PERSIST trial, which is the Pergovirus in Stratified Treatment for ART. We all love these beautiful acronyms, and we have to see what this PERSIST trial showed. So that was published in RBM Online in 2015. And the study was, do we see any improvement when we add REC-LH to REC-FSH versus REC-FSH only, starting on day 1 in older patient population? So I said older than 35, before there was this data that it may help in older women. Let's find out if it really makes a difference. So group A had 103 patients that received both, and group B was 99, and they received REC-FSH, but they added REC-LH on day 6. So they did not start on day 1, they just added it on day 6. And then they looked at outcomes. Again, this is an older patient population. The mean age was 37. 90% were Caucasian. Body mass were pretty nice. This is what you see in Europe. We don't see this in the US, unfortunately. FSH levels were the same on day 3. AMH levels were actually very good. This is a mean patient population of about 37 plus with very nice AMHs. Again, this is not the patient population. We see about 12 enteral follicles in these groups, which is really excellent. So canceled cycles was the same, number of oocytes retrieved was exactly the same, number of embryos transferred was 2 at that point, and this was a day 2, day 3 transfer. Most programs in Europe still do day 2 or day 3, and they put 2 embryos in each patient. The implantation rate was significantly higher in the group that started LH on day 1, not on day 6. Implantation and the clinical pregnancy rate was higher, and clinical pregnancy rate per embryo transfer was substantially higher. So it seems to be helping in these patient population, the older women, starting though on day 1. Don't wait till day 6. Now, the second study I'm going to review is actually the SPAR trial, which was published in January issue of Human Reproduction this year. So it's efficacy and safety of Pergovirus in ART in poor responders. So they looked at not just Bologna criteria, they went women up to 41 of age. The AMH, they went up to 1.3, even though with Bologna criteria it's less than 1.1. And that was an agonist study. So they wanted to suppress the LH as much as possible. You go with an agonist protocol, and then you start REC-FSH plus REC-LH at 2-to-1 ratio from day 1 versus REC-FSH only. And then you trigger ovulation with REC-hCG, oocyte retrieval, embryo transfer, like what most programs in Europe do, which is days 2 to 3 after, and then they use vaginal progesterone for luteal support. And these are the data. So whether you're less than 35 or more than 35, there was absolutely no difference in number of oocytes obtained when you use REC-LH in this study. About 3 eggs in each group, and again, overall 3 oocytes versus 4 oocytes at that point. What about outcome? Canceled cycles was exactly the same. Biochemical pregnancy was the same. Clinical pregnancy was the same. Ongoing pregnancy was exactly the same. Implantation rate was exactly the same. So in poor responders, adding REC-LH is absolutely of no benefit at this point. So in summary, REC-LH addition to REC-FSH does not improve outcome in poor responders. It may improve outcomes in older women, but you have to start it on day 1. Now let's talk about premature progesterone rise. So this is a huge topic that since actually the EV group published in 2010 the big trial of over 4,000 patients, it has reignited this whole thing. So up to Ernesto Bosch's paper in 2010, the literature was really divided into half showing absolutely no difference and the other half showing a difference. And the progesterone level at that point in the previous studies looked at 0.9. In Ernesto's paper, it was about 1.5. But let's talk about natural cycle a little bit. So in a natural cycle, the endometrial window of implantation is exactly the same as the embryonic window of implantation. Okay? So you have a nice LH surge, nice ovulation, nothing to really advance that endometrium. It's a perfect natural cycle. When you do stimulated cycles, you're going to have those that are still synchronous and those that become totally dysynchronous. But even when you stimulate, because the lining completely, everything changes. You have higher estradiol than normal, your progesterone levels is a little bit higher than normal. What you do when you do ovulation induction, you significantly shorten the embryonic window of implantation. So you really don't have the luxury of what you have in a natural cycle. And when your progesterone level rises, you're going to push that embryonic window of implantation beyond the endometrial window of implantation. Meaning, you're going to put an embryo in there that has no chance at implanting. Okay? So the train has left the station. So when your progesterone rises, I'm going to show you there are molecular changes that happen in the endometrium that makes this endometrium non-receptive for an embryo to implant. And this is really critical, and it is solely because of the high progesterone rise in these patients. So we all know that the more aggressive your stimulation, the higher the number of oocytes you're going to get, the higher your progesterone dose is going to be. That's perfectly known. Whether your total dose or your daily dose, the more aggressive your stimulation is, the higher your progesterone level is going to be. Now, what does it do? This is, again, a study from Labarty from the EV group looking specifically at what happens in women whose progesterone level is less than 1.5 or more than 1.5. And in the EV program, 1.5 looked as the value that above which implantation substantially decreased. Look at gene expression at this point. When the progesterone level was less 1.5, you get basically an ideal pattern for an embryo to implant. When it's above 1.5, you have an absolute shift in this. So the endometrium really changes, and this is molecular mechanism that the endometrium becomes non-receptive. And again, this is Ernesto's data looking versus agonist versus antagonist data. Once you exceed 1.5, the pregnancy rate substantially drops, but it's not zero. Okay? It's not zero. It drops in agonist to about 20%. In antagonist, it seems to be the endometrium is more dysynchronous in antagonist cycles versus agonist cycles, and the chance for pregnancy really when it exceeds 2 is about 6.8. And since then, multiple papers have been published to show that this negative effect of progesterone rise on pregnancy rates. And this is Venetis's Human Reproduction Update, which looked at more than 60,000 cycles of IVF, and basically looked at progesterone levels. And across every single progesterone level, the probability of pregnancy really diminishes. But there are substantial differences between poor responders, natural responders, and high responders. So the 1.5 level is not to be taken as an absolute marker. You have to know which patient population you're talking about. And more interesting, this is a study from the group in Brussels looking at whether your progesterone exceeds 1.5 or if it's lower than 0.5, the pregnancy rate substantially diminishes. Just like increased BMI, the heavier women and the very thin women both have lower chances at conceiving. But this is the first paper that I know of that specifically looked at progesterone below 0.5. So in here, you get advanced lining, and in here your lining is just not synchronous enough. So not enough progesterone to make the necessary changes for the endometrium to become receptive, and in here you have way too much, and therefore both become non-receptive. And these two patient populations in that paper were 22% of the patients. So basically 1 out of 5 patients that you have is going to have either a high progesterone or a low progesterone. So for those of you who are not starting to look at the low progesterone levels, you really need to at this point, and this is very, very important. So what happens back to rec-FSH versus Menopur? So this is the merit data, and in the rec-FSH group, there was a substantial drop in pregnancy rate when progesterone level increases. Not as much in Menopur. What about Megaset? Absolutely no change in Menopur versus a substantial drop in the arm that used Puregon. So it seems the hCG in Menopur is actually protective for this. So the premature progesterone rise does not happen too often. And we've had this conversation many years ago. Does pushing the patient for a blastocyst allows the endometrium to sort of recover in the 2 more days you're going to wait before you transfer? And the short answer is no. So this is a paper from 2013, showed that when your progesterone level increases, you're still going to see a substantial drop, even when you're doing blastocyst, which affects both clinical and ongoing pregnancy rate. And this is data from Shady Grove, the largest program in the US, looking at 1,620 patients, 934 blasts, and 686 cleavage stage. And what you see is actually that drop goes on. Whether you're putting good blastocysts or poor blastocysts, the pregnancy rate is going to linearly decrease. And once you hit about 2, it's a substantial drop in pregnancy rate at this point. And that's regardless of the number of oocytes you get. If you're a poor responder, your progesterone level is even, that affects your pregnancy rate is even lower, which is exactly what Veneticis has showed. That, and in high responders, it's about 1.8, in poor responders, it's about 1.1, 1.2. And if you smooth that curve, this is what you see between blastocyst and cleavage stage. At any one point, you're going to get a lower pregnancy rate when you're transferring a day 2, day 3 embryo versus a day 5. But again, you see that drop with pregnancy rate with increasing progesterone. Even above 2, there's still pregnancies. You know, that 20% that the EV group saw in 2010 is exactly what the group at Shady Grove is seeing. So if you have a patient that's insisting on having a transfer and she doesn't want to freeze, then you can still, but tell her she has a substantially lower chance at conceiving, but it's still about 20% if you have a blast. Now, does the duration of progesterone rise affect this also? Meaning, if your progesterone level rises just on the day of hCG versus it starts rising a day or 2 or 3 earlier. And this is a study that showed the earlier that progesterone rise starts, the worse your outcome is going to be. Okay? So if you're about 3 days or more, whether with agonist or antagonist, the pregnancy rate is about 50% lower. And again, with antagonists, it seems to be even more of a drop at that point. Now, what about comparisons between rec-FSH versus rec-FSH plus Menopur? So this is the famous paper of Richard Scott. Marie Warner is the first author, looking at what's called the sweet spot. What if you mix your medications, use rec-FSH plus Menopur, for example, what is the ideal ratio for you? What is called the sweet spot, which gives you the lowest amount of premature progesterone rise? So more than 10,000 cycles, retrospective review, and there were 5,400 for agonists and about 5,000 for antagonists. And they looked at the incidence of premature progesterone rise as defined as a level of 1.5 on the day of hCG administration. When you use recombinant FSH only, your premature progesterone rise is 40%. Okay? That's across the whole study. And the more HMG you add, and the only products in the US we had was something called Repronex, and then it changed to Menopur. Once that ratio becomes about 0.5, they get the lowest amount of premature progesterone rise. Okay? But there are substantial differences. If you're a hyper responder, you're going to make more eggs, and therefore your progesterone level is going to be increased. And if you use recombinant FSH only and you're a hyper responder, about 80% of your patients will have a progesterone level above 1.5. very, very important. And that's normal responders and that's poor responders. But everybody starts going down once you hit about 0.5, which is a ratio of FSH to LH of 2.1. But where is 1? So in that study, they had very few cycles that use monomenopure, and therefore they could not give us any idea what the incidence of premature progesterone rise was. So I looked at my own data. I presented this at ESHRE last year. So when you're using Brevell and Menopure, so this is urinary FSH plus Menopure, the incidence was 16.4%. When you use monomenopure, it actually dropped down to 2.5%. So that's one of the ways that actually that hCG in Menopure protects against this. And I will tell you in a minute why. So this is a fabulous paper that if you have not read, you absolutely need to read. This was published in the February issue of Human Reproduction. Now, I'm going to take you back to basic science a little bit, try to understand what really happens when you give recombinant FSH. So this is a basic science paper looking at 15 samples of ovarian cortical, and they got non-luteinized FSH responsive granulosa cell line. So they got this from Japan, and they said, okay, if we add recombinant FSH, what really happens? Can we see why that progesterone level rises? What's the molecular mechanism by which the progesterone really increases? And they added rec FSH at 12.5, 25, and 50 milli-international unit per milliliter. And then they measured multiple products at 24 hours and 48 hours. So again, let me take you back to physiology, to cell-to gonadotropin theory. You really have to understand this. So in granulosa cells, we have the FSH receptor. Theca cells, we have the LH receptor. So obviously, cholesterol breaks down to make pregnenolone, which gets converted by 3-beta-hydroxysteroid dehydrogenase to progesterone. However, in granulosa cells, the 17-alpha and the 17-20 lyase enzymes are LH responsive, and because there's no LH receptor on the granulosa cells, it cannot metabolize progesterone into androgens. So what does it do? It calls the theca cells and said, I'm in trouble. I have this progesterone that I need to convert. I just don't have Romanian money. I have US dollars. I need to convert those, okay? So it goes to the theca cells, which was making its own progesterone, okay? So at that point, the CYP17A system, which is the 17-hydroxylase and the 17-20 lyase, are LH responsive. At that point, progesterone gets broken down into 17-hydroxyprogesterone, further into androstenedione, down into testosterone. Now, the theca cell is in trouble because it does not have the aromatase enzyme. So it has to call the granulosa cell and said, did you a favor, now I need you to do me a favor. I need to convert these androgens into estrogens. And these are all FSH responsive steps. Now, what happens during ovulation induction? When you use FSH only, you're going to have not enough LH responsive, so there's not much of an LH response to drive that progesterone further down. So what happens, you get progesterone that's coming from granulosa cells, and there are many because you're using ovulation induction. It's not a natural cycle. So you get a large amount of progesterone that's made by both the granulosa cells and the theca cells, and they cannot convert it fast enough into androgens, and therefore it seeps into the circulation. That's exactly how rec FSH works. And without an LH, quote unquote, activity, you're not going to convert enough progesterone back into the granulosa cell, seeps into the circulation, and that's why the progesterone level is higher in rec FSH only cycles. It's a superb paper. Okay, so I'm going to touch a little bit on hyperresponders at this point because this is a contentious issue. What do you use? Can you use HMG in hyperresponders? And sure you can. You can use it in anything. So this is actually data from the MERIT and MEGA set, where they looked specifically at those patients that made 15 oocytes or more. And as you would expect, the chance at having women with more than 15 oocytes is substantially higher with rec FSH, both in MERIT and in Megaset. And again, that these are women that are at risk at producing more than 15 oocytes. And we saw the Recovel data yesterday, which is exactly showing that when you use rec FSH, but you start with the right dose, your incidence at having more than 15 oocytes is substantially diminished. And there are higher birth rates, even in hyper-responders, when you're using Menopur versus FSH. Why is that? I just showed you the basic science paper. You're going to convert that progesterone, and you're going to have a substantially lower concentration of progesterone in the circulation when you're using Menopur versus recombinant FSH. As I showed you in my study, it was only 2.5%. Now you're going to tell me, well, you know what? I don't care about the progesterone issue. I'm doing freeze all at this point, okay? So what's going on is definitely there's an increased usage across the world. And in some parts, 100% used, okay? However, we have no evidence at this time that this is really the way to go. But there are 5 trials going on at this point. I'm going to review those with you. If you don't have a fantastic lab, you're definitely doing your patient a disservice. And even if you have the best lab in the world, you're still going to lose some embryos when you freeze and when you thaw, okay? So time to pregnancy, that's substantial also. For us, our patients, when they go through an IVF cycle and they get a period, whether you're doing freeze all or not, for them, this is a failure. And you have to also add the time, the cost, and the emotional burden. In here, very few patients can afford to freeze their embryos to have a frozen embryo transfer afterwards. However, there's enough data that when your progesterone level rises, this is really the best course to do. So this is, again, a paper from Shady Grove looking at the pregnancy rate when your progesterone level goes beyond 2. So if it's less than 2, the pregnancy rate is 45%. It drops to 15% when your progesterone goes above 2. So 2 is extreme, okay? So 15%, it's never 0, but it's 15%. It's never 0 unless your progesterone level is 3 or 4. And this patient, you're not going to get any eggs when you do your egg retrieval. But when you transfer them, if you freeze them and then you transfer them in a frozen cycle, the pregnancy rates were identical. So this is a fantastic way if your progesterone level really is high. So I'm going to review a little bit of the literature that just came out. This is the famous New England paper that came from China, looking at freeze-all versus fresh transfers, specifically in PCOS patients, okay? So, of course, in China, they can do this study in 2 days. They had 750 patients in each arm. And you know, the biochemical pregnancy rate, so they randomized them into fresh versus FET, okay? Specifically PCOS patients. And the Chinese PCOS patients are all thin patients, and they're quite brittle. The pregnancy rate was exactly the same, 58.7 versus 56.2%. But in that paper, there was a lower pregnancy rate in the fresh versus frozen. Why was that? The amount of patients that lost pregnancies in the second trimester was 12%. This is huge, okay? How many of your patients lose their pregnancies in the second trimester? God forbid, they may have a car accident, they may rupture the membranes, but it's usually a disaster, okay? In that study, 12% lost their pregnancy in the second trimester. It makes absolutely no sense. So as far as I'm concerned, I will go with the clinical pregnancy rate as what you should look at, and it is identical. So even in PCOS patients that are the highest risk at developing premature progesterone rise, there was no difference in the Chinese population. One of the things that we don't know about this paper, which, you know, unfortunately the reviewer did not ask for, is what medications were they using to stimulate. Was it recombinant FSH, or was it a mixture of recombinant FSH plus hMG or hMG only? I think this is really substantial, and we have absolutely no data whatsoever on what happens. Is there more recent data? So these are the 5 studies going on around the world right now, looking at freeze-all versus fresh transfers. Okay? That's the Vietnamese study, a study in Canada, a study in Denmark, a study in Hong Kong, and basically the largest one is ongoing in the UK right now. It's called eFreeze, and Abba Maheshwari is actually the lead investigator on this. Do we have any preliminary data on these? Yes, we do. So ASRM late breaking session. So this was presented October 19, 2016, actually Wednesday morning. And looking at this, so what they did, so in Vietnam, they transferred on day 3, and they did exactly a fresh versus a freeze-all, and say, let's look at the outcome. Are there differences at this point? So I'm going to show you the results. Ongoing pregnancy rate is exactly the same. Multiple pregnancy rate is exactly the same. OHSS risk is exactly the same. Ectopic pregnancy is the same. Delivery less than 24 weeks is exactly the same. So at this point, as far as I'm concerned, looking at the Chinese data in the worst patients at risk of premature progesterone rise, and the Vietnamese data with 400 patients in each arm, there is no difference at this point, okay? So please keep doing what you're doing. Our patients are coming in to get pregnant the first cycle, but please don't overstimulate your patients. You really need to keep that progesterone level in check. And I'm going to end with these 2 studies. So one of the speakers yesterday mentioned this a little bit, and I'm going to expand very minimal on it. So this is Santiago Muniz, who heads a genetics program in the US called Reprogenetics. Not just in the US, it's actually around the world. But they specifically looked at the US data. And they looked at donor oocytes. So they're going to remove the effect of age. So all of these are younger than 32 normally. Are there differences between programs? And there are huge differences. So it depends how you stimulate your donors even. That will affect how many euploid embryos you're going to get. So these are 42 centers in the US. And so Professor Hamama actually spoke about this yesterday. The differences are substantial. So one program, the programs in red are programs where they had substantial differences in versus the good programs, meaning they got significantly lower euploid embryos, even in donors, okay? So 40% versus over 80% in here. So now, what do you think is the big difference in here? There's 2 things. One, we don't know anything about ethnicities of those, okay? In the US, you would assume about maybe 70, 80% are Caucasian, but that's not always the case. We have, for those of us who have dealt with Chinese donors, for example, or Indian donors, they have substantially reduced ovarian reserve compared to age-matched Caucasians. So a 32-year-old Chinese donor is like a 37, 38-year-old Caucasian donor. And Indians are practically the same. So what's the second characteristic? How you stimulate. So these are donors. If there's a trend, if your program is one that does freeze all, what do? They're going extremely aggressively. They want to get as many eggs as they can. They want to get 35, 40 eggs. And when you do this, what do you do to your eggs? You're going to make them more aneuploid. Okay. So this is first evidence right now that it's they didn't say the stimulation, but there are differences in programs. And as far as I'm concerned, the only thing that makes sense in a population that's mostly Caucasian is how you stimulate your donors. So please, you don't need 40 eggs to get your patient pregnant. If you can get 14, 15, which is really the ideal number of oocytes you should get, your euploidy rate more than likely will be at the highest level. So in conclusions, recombinant LH addition to rec-FSH does not improve outcome in poor responders. So if you're using it, please save your patients money because it's not making a difference. Higher serum hCG level during ovarian stimulation, you're going to get better outcomes in ART. Addition of hCG containing monotropins decrease the incidence of hyperresponse and OHSS. And menopur use seems to decrease the incidence of premature progesterone, which is critical when you're doing fresh IVF cycles. The use of menopur as monotherapy, it's really the ideal mixed protocol because you have 75 IU of FSH and 75 IU of LH, along with gentle stimulation, not mild stimulation. You need to get those 12 to 15 eggs, maximizes embryo quality and keeps progesterone levels in the desired range. And emerging data strongly suggests that the aggressiveness of stimulation, possibly the type of gonadotropin used, will affect embryo euploidy. Definitely cool off on the freeze all, at least until we have data. If you are a program that's offering freeze all, you are not doing your patient a service. You may be making more money, but you're not making your patients any, you're not giving them any service at this point. And I'm going to stop at this point and entertain any questions anyone may have.